Hey, it's Mark Slater here with Prime Spine Consulting, and I'm so lucky, honored to have Dr. Evan Katz with me for this interview today. Dr. Evan Katz is a chiropractor at Katz Chiropractic and Rehabilitation Clinic in Boulder, Colorado, with his wife, Shauna. Evan owns another business called Professionally Integrated. And Professionally Integrated is why I'm having Evan here on this interview. Because as clients of mine, I get questions about what should you be presenting to these attorneys at lunches or Zoom calls, and how can we amplify these Zoom calls, and how can we really separate ourselves from the rest of the chiropractic profession in personal injury by using Evan's product and what he offers. So Evan, welcome to the interview.
Thanks so much for having me. Super appreciate it.
All right, man. So let's talk about that. Why do some chiropractors feel like all the attorneys are going to cut their bills 50% no matter what? I hate PI. I hate dealing with these attorneys. Tell me your perspective on why some chiropractors think like that.
Well, I think some chiropractors think like that because that's their experience, whether it's their correct experience, I mean, it's their experience. And, you know, I think that just because you're a chiropractor, you can see personal injury. And just because you're a chiropractor, you can see babies. But there's a specialty, I think. You know, I don't treat infants. My license will allow it, but I don't feel comfortable doing it. And when it comes to, you know, trauma, auto, med, legal, there's a whole level of expertise. So I think what happens is a lot of chiropractors like, oh, I'm going to do personal injury, or they're like, oh, someone that came in was involved in a crash. I don't usually do this. They're already, you know, kind of starting a running race with one broken leg. They don't really understand what needs to be done. And I want to get it to a point where, you know, any doc that I talk to or try to help, that it doesn't matter if the person is in a crash or not. We're just treating a certain way and we're validating our treatment. So I think a lot of times what happens is chiropractors like, oh, I'm going to do this. I'm going to treat this patient that was in a crash. And then they start getting questioned by the attorney or by the defense attorney, the insurance company, like, okay, well, why did you treat? Why did you bill this? And then they're like, well, someone told me at this quick seminar that I could bill for this. And then all of a sudden the attorney is like, look, we're going to cut your bill 70%. And then we hear the chiropractor come and say, oh, they're asking me to take 50, 60% off. What should I do? And it's like, I don't know what to tell you what to do. Like, give me all the details. What did you say? What did you document? Did the patient get better or not with your care? What were you treating for? And if you don't have any of that, then they do have a correct experience, that it was a bad experience, but they chose that bad experience for themselves.
Right.
Does that make sense?
Yeah. So you said, what's in your notes? Meaning if it's just saying whiplash, myositis and myalgia, and lumbago, it's not really giving the attorneys enough to, you know, dig their heels in and get a high settlement. Yes.
Well, it's also not really given a real rationale as to why you're treating them. You know, it's great to say, hey, my patient I'm treating them for neck pain, right? Like, okay, so you have cervicalgia. And my joke is, okay, if I slap you on the back of the neck, or you get stung by a bee, or you get in a car crash that tears the ALL, or God forbid you have bone cancer in your neck.
All are cervicalgia.
My neck hurts.
Yeah.
Right? It's cervicalgia. Exactly. But the difference between like a, you know, cervicalgia due to a sprain strain that could be self-resolving is different than cervicalgia due to facet capsular instability. Or you know, another particular pathology that we can then get specific about, and then we could discuss why our treatment was reasonable and necessary for potentially long-term. But if you're just saying it's cervicalgia, and then 6 weeks, 6 months, 6 years later, you're still saying cervicalgia, but not why they have cervicalgia, then you're not doing your patient any favors, nor are you able to explain the true benefits of what our treatment is for a particular pathology.
Yeah, right. Like, so in my business, I just help these doctors get more PI patients. I don't help them clinically. But Evan, you were so good at clinical excellence, and for the sake of this interview, we focus on personal injury. So why don't you show what you have and how it works, why it works, and then we're going to get into, because you mentioned instability, like how do we diagnose instability, and then what do we do with that, and how do we convey that in our communication and our notes, and why that has so much value long term for the patient.
Right. And a lot of it is, I find it interesting that, the way I set this site up was, this is what I use to build our practice, right? Like I want to educate our patients, right? The attorneys are the last people, right? The first people are our patients. They should know why they're in our office. They should know why they hurt. They should know why certain activities after a trauma, like a crash, are causing problems. And all the research, 99%, right? You're always going to find that one literature that says smoking's not bad for you, right? But all the research clearly shows that one, patients get really hurt in crashes, that two, there's lots of pathologies that can occur. But ultimately, most of these pathologies are truly structural, functional pathologies. And what else can really be validated for a structural or functional treatment? Us. So we can validate our care if we document it correctly and educate our patients on the importance of our care. So I'll show you, like, what we use, and again, I'm a full-time, we have a full-time practice. I basically feel like I'm giving this site away because I want everyone to have it, right? I want to show what this is, and if everybody drops off tomorrow, the site will still be up because I use it every day, right? It's how I keep myself sharp. It's how I keep myself educated. It's how I keep my patients educated and use it for newsletters and other things.
Okay, so let's see how we can make personal injury doctors, or just chiropractors, or any doctors just in general, just better, because the doctors are the advocate for the patient. So the patient is depending on you, in our case, to get them well, but also get them a better settlement for pain and suffering, whatever, but also just get paid yourself for the hard work that you went $100,000 in debt to acquire.
Right. And I think also with that is, we're trying to explain for our patients, like our responsibility if we take on a patient, especially a med legal patient, because we are responsible to explain why that patient needs care both today and the long term. And it's our duty, especially when you take on this case and you're billing insurance and you have a legal and ethical obligation to explain what's wrong, right? So if we can say, hey, I put in your notes and documented why this is a problem, what the long-term implications are, how we're helping, then your attorney could say, oh, thanks, because we have one bite at this apple to show the insurance company why you need care. And we can only do that based on the Etherton law, the four corners of our notes. So I make it really easy, like, here's the information, here's the research, here's the diagnosis, to explain from a causality perspective, do crashes cause these pathologies? To what are their issues from a physiological, anatomical perspective? And then what are the short and long-term consequences of these pathologies? So when somebody says, let's say for cervical kyphosis that we're trying to fix, oh, they should have been better in 12 weeks or 12 visits or whatever the typical IME response is that's very simple if you're documenting cervicalgia or whiplash or headaches and maybe even slight AOMSI. But if you start to put the literature in that I have on this site, from like Journal of Neurosurgery, Journal of Clinical Biomechanics, all surgical healthcare, Journal of Medicine, that says this pathology will lead to decreased quality of life, will lead to further arthritis, will lead to abnormal vascular supply, will lead to central sensitization. Now we just went from a self-resolving injury that the insurance companies try to argue to, our notes actually say it will irritate the spinal cord. Our notes actually say left untreated, it will lead to further arthritic changes. So show me what you came up with that says this will get better, because the research that are in my notes from these journals actually show it will get worse without our care. And now you have the validation for your long-term care that they're going to need. And now the attorney could say, hey, the notes clearly show this. You need to pay for their care for the next 20 years. And here's the research. So now an IME has to come in and do one of two things. They either are going to read it, straight up lie and ignore it, or they're going to have to address it. And what are they going to say? Well, I disagree with all this research peppered throughout the notes. And now you can validate the treatment that you've already given and the treatment that the patient's going to need long-term.
Got it. So let's see your product in action and how it can help doctors. I mean, you make it so easy, so searchable. You make it easy to, well, I made you the host, so you can go ahead and share your screen and turn the magic.
And I made it easy over the years because I've been in trial so much that I realized, like, oh, you know, when the defense attorney asks a question, I never look at it as they're attacking me. I'm like, okay, well, let me just answer the question. And every once in a while, you're like, you have a good point, right? So then it's like, over the 20-something times I've testified or whatever, then I go back and I'm like, that was a good, let me answer that now. So I just have it already streamlined to validate, and not to necessarily advocate for the patient, not to beat an insurance company, but to just show what the science shows, to show why we're following a particular course of care and why we're able to help these patients. And without us, unfortunately, the high majority will end up in chronic pain, you know, and that's the problem. So yeah, I'll show you. Do I do it on my end here?
Yeah, I made you the host, so you can click on the bottom, share your screen, just go down.
Oh, I'm already, okay. Yeah, so I'll show here. Bless you. Was that a cough or a sneeze?
You know, it's a combination of both.
Okay, it's a competency. So here's the site. I'm just going to try to move this bar. Can you see my screen?
I can, yeah.
Okay, so here's the site, professionallyintegrated.com. And let's say, you know, down the bottom, I always have videos and then recent things that we already put up. I did a video on jaw, cervical fusions. Here's a paper that I go over that recently in court they tried to use to say people don't get hurt, so on and so forth, right?
So it's a low impact paper and how you can combat that if you go to court and they say, well,
this was a paper. This was a paper that I recently testified in court, and I just did a quick like synopsis of it. That you can watch and break down the paper. It kind of talks about you know what's happening. And it's just, it was an important paper because the insurance company tried to use it to say that, you know, hey, this shows that people really don't get hurt, but I need to make aware, I wanted everyone to have it, to be aware of what they show, but actually what the true aspect is. And what it actually showed was that these were low impact, that 15 of these people actually needed medical attention and 3 became disabled. So their own paper that they say people don't get hurt actually shows that in low impact, people actually become disabled. And disability was, it wasn't even like they were hurt, they just couldn't even work. So, you know, I have stuff like this, but let's start with like, let's say a patient has a loss of curve or something, right? They come in, you x-ray their neck, it was after a crash, and you want to look up loss of curve. And I have everything here from research. So I'll put up here loss of curve and neurological problems, knee osteoarthritis and lumbar, as well as quality of life, cervical kyphosis surgery. So let's say you're like, you know, this patient kind of has some neurological issues. Let me see what this shows. And I show this to the patient and I'm like, oh, okay, this was from down the bottom. I have it really quickly. So you could just copy and paste, put in your notes, the research. This is from Journal of Neurosurgery. And then I'll take a sentence or two. And I put here, I'm like, okay, longitudinal distraction or loss of curve is a possible factor in progressive spinal cord dysfunction. And this is often discussed clinically as tethered cord syndrome, right? And then down here, you diagnose them with a kyphosis and instability. And look what Journal of Neurosurgery says. Patients with kyphotic deformities, the spinal cord shifts to the anterior portion of the spinal canal and abuts the posterior aspect of the vertebral bodies at the apex of the deformity. With a progression of kyphosis, the mechanical stress applied to the anterior aspect of the spinal cord eventually increases. In addition, let's say you diagnose with instability. Dynamic forces from segmental instability, which is often seen at the level of kyphosis and cervical flexion movement, contribute to compromised cord function. Copy, paste, and put in their notes. And then you can listen to it as a podcast just on every single
low professional
down the paper.
Portion journal.
So
Let's take a look at.
I'll print it out, hand it out to patients. And now what we just did, just with that one soap note, is I discussed that Journal of Neurosurgery suggests that this pathology that I diagnosed and measured on X-ray irritates the central nervous system by abutting the spinal cord and minimizing vascular issues. That's just one paper. I throw it into my notes. Now an IME 6 months later says, oh, it should have been better. Really? Well, we already had this paper in here. And you could just go on, right? Whatever you're trying to look for. And I have, I don't know, hundreds of articles on here. Like, oh, well, how do you know a car crash causes that? You could look at causation. Here's a paper from, actually, this was from Yale, from White and Punjabi. And they actually show that a 2.5G trauma, low impact, causes, and you can just copy and paste, put in your notes, damage to the ALL as you measure on flexion or on extension, right? So now you have an ALL ligament tear. You show that even at low speed, it causes a trauma. And they also show that the mechanism of whiplash injury is an S-shaped curvature, which causes that buckled shape, so you know it's from the crash. And not only did it damage the ligament, but it actually elongated and stretched the vertebral artery. So now you have a ligamentous injury at even just a low impact, causing an abnormal buckle S-shaped curve, which if you see on X-ray, and that affects the vertebral artery. So that is not a whiplash injury, right? Now, how do those symptoms occur? And what does that mean? And how do you find that? And I have tons of webinars where I have even videos on here on how to do an appropriate initial examination for loss of curve, and how to do an examination to diagnose instability and what that might show, discs, facets. And then it comes down to like, okay, you have instability. What does instability show? What if they have a facet injury? And it just goes on. And I just use it for patient education. Like, oh, look, hey, Mary, your head was turned in this car crash. And how do I know? Because I asked. Well, here's a video I break down for you on a position and how that affects the facet joints, how it affects the ligaments, why that's a problem. We have causation, head turn makes it worse, facet injuries, instability and nerve compression. It just goes on and on and on, right? Journal of neurosurgery, spine, it shows what happens with instability and how that causes really significant problems and decreases the patient's quality of life, right? And that's just, and then obviously the great thing too is I have tons of webinars. I can go on forever, but I just use this in some of my patients.
But so how we can use this practically is obviously copy and paste all that information into the notes. That's also tagged or referenced by a medical journal of neurosurgery. So hard to argue with that. It comes out of medical journals.
And what you're doing is you're using your clinical experience to say, hey, I've seen this before, but I'm also relying on this research. And normally what we see is like, oh, this patient has a loss of curve and it's not measured. And then an IME could say, I don't think that is a loss of curve. And there's no numbers, right? So then it's a he said, she said. This is like, look, this is my clinical experience. And here's peer-reviewed public research, because there's no peer-reviewed, there's a lot of peer-reviewed research, not a lot, that an IME can use and say, hey, some people that get hurt have psychosocial issues, right? And you're like, all right, they're trying to say the patient is crazy or they're malingering. But it's really hard to do that when you're like, how can you fake these objective findings that we were then able to link to their subjective complaints that we also were able to link to doing an appropriate evaluation. And when we look at doing their initial, like, okay, let's say they had change of sensation in a certain area or pain. And, because what I see a lot in the notes is I see these docs, there's these programs like, okay, they did, shoulder depression test, and a positive test is neural sleeve or something. And then they're like, it's negative. I'm like, well, shoulder depression could also be SEM. It could also be facet. It could be sclerotogenous. So you need to talk about that. Like, hey, patient doesn't have radicular, but they do have sclerotogenous pain to the medial border of the scapula. And then you can come and like, we can just do like, okay, you want to look at that. I just have stuff here where you're like, okay, let me just type in patient has some sclerotogenous pain. And I just show the patient that, and I'm like, oh, let's take a look at what does this actually mean? Oh, here's a video on axial neck pain. Here's what it means. Here's a picture of it. And then I can even give you a diagram here where you can just put in your notes like, oh my gosh, this patient had pain in this region. It's not, radiculopathy, but it is sclerotogenous pain. And then we went back into their images, their initial exam. We showed that it was a problem. And okay, well, big deal. So then you're like, okay, well, what do you mean big deal? Like, let's look at what is facet pain. And if you want to look at like, you could put instability, you can look at chronic, right? Like, is it going to be chronic? And I try to put these keywords in. So I'll look up something like, all right, what's information do I have on instability and chronic problems? Here you go. Okay. Right. Here's instability. Like, oh, let me look at instability and loss of ligament strength after a car crash. Like, is this chronic? And I break out the papers that show, with videos for you to understand what it means, highlight, put in your notes.
So
And
like,
obviously,
let's say I'm a personal injury attorney and you're showing me this stuff and we're on a Zoom call and this is our first meeting. Like, none of my chiropractors that I work with have this much information, reference to medical journals to validate the why of your care, why the patient needs this care, why you're treating it, and the long-term prognosis, which most doctors, I mean, in my experience, don't know how to adequately explain that other than just guessing and speculation.
well, and it's not only that, it's also, okay, so you diagnose loss of curve. So you diagnose AOMSI. The question I was asked was, okay, well, what does that mean? Why is that bad? Well, because it's unstable and it's a 25% whole body impairment. I'm like, no. How is that affecting the patient? And when you put that in your notes, and look, showing this to attorneys all the time is, look, I've taken all the Whiplash courses, right? And I felt like there was a big void, right? They talked about how people got hurt, but it never talked about what does it mean, right? Like, okay, so you diagnose a facet injury, like, okay,
what does it mean?
And
right.
Well, there's studies that I have on here that a facet injury within a 24-hour period actually affects the spinal cord and can lead to central sensitization. So now you have information and like, look, we diagnosed facet based on, here's the initial eval, which, is on here. Here's pain patterns. Here's the diagnostics that we're able to show as a facet. But here's research that shows that not only is that hurt, but it can literally affect the central nervous system, leading to central sensitization. And that might be why these patients are chronic. It might be why they're more sensitized. So that went from, I diagnosed this, to, look, this pathology that was caused by this crash, that was diagnosed here and shown here, both subjectively and objectively, is leading to this person being more sensitive to pain, to having more chronic pain. And then I just have it all for you to show why. And then it's, okay, well, what does chiropractic have to do with a facet joint? Well, what does a facet need to be healthy? It needs proper mechanics and proper movement. What are we doing? It doesn't need a cortisone shot to numb it. It needs proper mechanics. So now you're validating your treatment to help and to get better. So that'll make a difference.
Okay, Evan, so you mentioned, instability in certain structures. How can we diagnose instability and how do we talk about it? So let's talk about that a little bit. And also, you have a soap notes tutorial in your product as well.
Yeah. So instability is needs to be diagnosed in a couple of ways. One, and this is why I don't really like to use the diagnosis codes, and I talk about that somewhere else too. I have a whole thing on that with diagnosis codes. Is instability can be evaluated in a number of different ways. Instability usually for PI is talked about just AOMSI, 3.5 millimeters of translation or over 11 degrees of angulation. But White and Punjabi discuss that an abnormal cervical curve is a sign of occult instability, because the normal, established normal, is a normal lordosis of the neck. If you lose that, that structure is no longer stable. Right now, that's a global instability. That it's an unstable neck that leads to, it's weaker, and I have all that stuff on the site to show patients and document. But we also did the largest, me and a bunch of other docs, MD, PhDs, we did I believe it's the world's largest cervical instability paper, where we compared injured versus non-injured necks, and we looked at 37 parameters. And can I steal the screen for a second?
Of course.
So this is how, I start with flexion extension images to begin with. Okay, that is a great way to determine instability, right? You look at measurements. The measurements are all in here for you to look up and see how to really analyze it.
Okay.
But the paper that we did here really shows what we went through. And we got this, it was titled Diagnostic Accuracy of Video Fluoroscopy for Symptomatic Cervical Spine Injury Following Whiplash Trauma. And this was published in International Journal of Environmental Research and Public Health. And what we did is we took about 119 injured and 70-something uninjured patients, and we looked at all the parameters, right? We looked at lateral overhang, and this was on DMX, right? Not just X-ray, because there's a lot of mid-motion problems that are also considered unstable that we found and established, right? So we looked at lateral overhang, we looked at translation, we looked at spinous process engagement, we looked at all these different facet gapping, and this is how we determined stability. So the way that we looked at this was we looked at all these different parameters, right? What is the millimeters of movement, how much? And there's a lot of literature now that is discussing that 2 millimeters is actually unstable and not 3.5. And that's what we found as well. So we looked at, this is the symptomatic group, 119 people, 77. These were all blindly read multiple times. And as you could see, we could see how many percentage of patients had instability of these different findings, right? Like, okay, what's C1 overhang? 63% of the injured had it, only 32%. Periodontal space, 28%, only 3.9% of the asymptomatic group. So we can really determine what likelihood of a problem this patient is of being injured, right? So, if we look at, let's say, C2, C7 facet gapping on DMX at 5'6", 37.9% of the patients had it that were injured, and no one in the non-injured group.
Wow.
So when we start to see these pathologies, we can start to say, we know that this likelihood of injury. So there's 37 parameters of instability that we need to look at to be able to determine if the patient truly is unstable. Now, that doesn't mean if you have C5, C6 translation at 3.5, that's not enough to say that they're unstable, but you might be missing a ton of other parameters without doing a DMX. And I have no vested interest. I don't own DMX or anything like that. I just have one. And we were able to determine now the likelihood of injury based on 37 parameters. And you have to remember too, when you do AOMSI, you're really only measuring 66% of the segments and maybe only 10% of the movement. You're just looking at flexion extension, but you're not measuring C0, C1, C1, C2. That doesn't count because there's no discs there. So you don't get, it's a different translation and angulation of those regions. So really you're just measuring 2, 3, 4, but you missed the top 3 segments. On this, and there's a huge difference between C6 instability and C0, C1 instability. But what do they have in common? Diagnosis of instability. Okay. So if you're just saying, oh, the patient has AOMSI, it's unstable, like, whoa, back up. Is it the alar ligament? Because there's a lot of evidence that if it's the alar ligament, 50% of those people can become disabled. It also is around their brainstem compared to their cord. Not that, but you have to look at those things, right? If the patient was hit, they were unaware, they were looking in the rearview mirror, those are shown to damage the upper cervical spine and the facet joints. But if you don't look on DMX of the upper cervical movement or the facet joints that we published, you're missing it. So you might not have AOMSI of just those 2 measurements, but you still have the diagnosis of cervical instability. And that's what most docs miss. And then they don't know how to really treat it, evaluate it, or even what it looks like on initial exam or in the history taking. And we have, I have a whole webinar on just evaluating and, doing an initial exam, evaluating imaging of the upper cervical spine.
Okay, so that you could help these chiropractors translate that information into a report so that it makes sense.
Right, and so that it reflects in your history, in your initial evaluation, and what you find, right? So AOMSI is, okay, they're unstable, like where? And then the question is, okay, what does that mean? Right? Like that's where, most of these PI programs that I've taken, they're 20 years behind. And we keep learning the same thing. Dude, I'll put a new paper up every few weeks, and it's something that we didn't know last week. So how can we still be doing the same thing? We've learned so much more. And we've learned so much more on how our care is mandatory, or it should be, if we do an appropriate job. And then with me or with this site, is, I mean, not to sound cocky, but you see all these other docs that are learning like, oh, the Colossus easy buttons, how do I bill, how do I do? They're not educated on the real injuries, or a lot of them aren't. Some are, of course. My site is to educate you on these injuries. So it's for every patient. And you have a great marketing program, right? It's an awesome marketing program. But here's the problem. Not with your program. You're going to market this, you're going to do this great job. You're going to get this doc in front of 5 attorneys. And those 5 attorneys are going to want to work with that doc until those 5 attorneys meet a doc like me that I can educate them on what those injuries really mean. So it becomes who's working harder, right? Who's working harder, who's working smarter, who's staying on top of the education that is out there.
Yeah,
that's the key, right? Like you have the education, like pay Mark to educate on what works for, getting your name out there, getting it out there. But what are these docs doing to really learn about these pathologies, to really learn on how to educate, to really learn on having your notes reflect on the significance of these problems and our treatment? And my site just puts you in front. So every time I do a webinar or a Zoom or a presentation with my site, 9.9 times out of 10, I get the exact same thing from an attorney. And they're like, how come no one else is telling me this? I'm like, I don't know, but just you don't need to know. Just send all your clients to us and we'll make sure they get appropriate evaluation, documentation, treatment.
Yeah.
And then that makes their job easier.
That's right. Because in our pre-interview, I asked you, when you're talking to these attorneys, I asked you, like, what are the frequently asked questions that you get, back from the attorneys? And because you want to understand their pain points. And do you remember what you told me when you asked these attorneys, like, what is their pain points when working with doctors?
You mean like what I say, what do they normally get as a diagnosis?
Yes.
Yeah. I have a funny story from 2 weeks ago that I always say this. I said, before we get started, and again, 99% of the time, I get the same answer. The 1% I don't, I'm like, oh, that's cool. You're right. Like, oh, good. You're getting good docs.
Yeah.
I always say, before we get started, what's the main diagnosis that you get? Like, what do you get from chiropractors? Like if a chiropractor sends you a patient, what's the diagnosis? And they're like, oh, headaches, whiplash, cervicalgia. And I'm like, look, it doesn't matter how good you are as an attorney, you're done. Like, unless all of your clients are super lucky and they're not really hurt. Right. Like, and that's best case scenario, right? We want that patient that the attorney hates because we got them better 100%, right? That helps our practice more than anything, right? Like, oh my God, I'm totally better. But the majority of these patients, that's not an appropriate diagnosis. So then that's when we lead into this site, like, oh, here's what I'm going to do. If I send you a patient, they might be diagnosed with this and with that. And let me show you some research that shows how this can affect their central nervous system. My notes are going to show that. Is that something you're interested in? I don't ask them for referrals. I don't need their referrals. Like, I want to get my patient to the right person. And then they're like, absolutely. I'm like, okay, so just so we're clear, if I send you this, you need to ask questions and do not cut my fees. Like, I'm giving you the information that you should be able to get policy limits, because my notes are going to reflect that this is not self-resolving. This is not just going to get better. They're going to need more than 12 weeks of care. And it's going to reflect that. And they're like, absolutely. And then that's what happens. And it's not like advocating for them. And it's not, trying to pull the wool over the insurance company's eyes. They're trying to pull the wool over our eyes. There's no evidence that these pathologies, if accurately diagnosed, that's in the literature, are just going to get better. In fact, it's way worse. So we have to be able to reflect that and explain that from day one, and then just pepper it throughout your notes. And I show you how to do that. Right.
And you mentioned, like, you don't market for PI anymore. Like, you're not doing any outward community outreach anymore, because you've established yourself, and your notes and your documentation speak for themselves. And that's why you don't market anymore, because these attorneys know, if I send my client to Evan, I'm going to get home run notes, a home run report, and the work is really done for me. I can get it for settlement.
Yeah. And there's also, like, it's frustrating because, look, there's a lot of attorneys that don't want to work with me because they're going to mail it through. They don't want this information, right? And that's not the best.
They have to work harder.
Well, they're going to have to be liable for what my notes say, right? So if you settle for 10 grand when there was a $25,000 or $50,000 policy that shows that they have instability in your upper neck that caused this, like, you have to answer why you did that, right? Compared to the other ones that understand and like, oh, so it's just finding that you have to find the attorney that wants to practice like I do. I don't want, to see 3,000 patients a day. I want to, you like, and
Quality
I don't want, and I don't really want to send my patient to a law firm that they just have 50 paralegals doing all the work and they're just milling it all in until they get that one tractor trailer case that, all the rest of them kind of just pay the overhead and then they finally get one for profit. Like, understanding what these injuries are, so we're all on the same page. And it does take time. Like, we still do some outreach, like, hey, we want to show you this, right? Like, we were at an event where we met attorneys and we were talking about this, and it's like, let me show you this. And like, how come? And that's a whole other story, but it's like, and I asked him that exact question. I was like, what do you normally get? And I expected from this person something different, like, oh, it was two of them, cervicalgia, headaches, whiplash. And I'm like, oh God. I was like, but again, I was like, I should be mad, but this is a great part for my business. Let me show you why you should send to me. Here you go. And so it's like, you're going to, you with your work can get me in front of those attorneys, and you could get 10 other docs in front of those attorneys. But if we're all competing, you're going to compete with me, right? And you're going to go and you're going to talk to these attorneys about what you could do and how you can cut corners and take 10% off. And I'm going to go in and be like, I'm not taking a dime off, but I'm going to get you more because we're going to explain what these injuries mean. Who do you think you're going to work with?
That's right. And your clients you mentioned are typically getting 50% more in their settlement offers than just the run-of-the-mill chiropractors down the street from them.
I mean, I don't even know. Look, I can tell you that every time I've been in the trial, the average, I think, is like $400,000 jury verdict because we could explain what's wrong, right? And I hear people all the time like, oh, this won't work here. And it works in every state. We just had, another doc in another state. I think it was somewhere on the Southeast. I think it was Dr. Dustin Taylor. He got like 30-something grand, 35,000 on a case because he used the site. And what's crazy is do you think, I asked chiropractors this, do you think a $30,000 chiropractic bill is a lot? And if they say, yeah, I'm like, why? These patients, you just said in your notes, they had AOMSI, they had a permanent injury. And that permanent injury can do what? It can lead to worse outcomes. It can cause spinal cord. But you think that your treatment that's minimizing that from happening and hopefully you show you're improving it isn't worth that, but one injection to numb it could be worth 10 grand? Like, why is that not worth it? It's adding the value to the care by using the science and research to examine and evaluate how we're helping long-term. And I still say, hey, if I reduce that patient from getting one injection a year over the 4 years, I save the insurance company 10 to 20 grand.
It's a great point. I mean, it's a super point. So to provide more social proof, you showed me a post about one of your clients that got a really big settlement check. Mm-hmm. And I think the patient didn't start care. You said a few.
Right.
Can you share that post?
Yeah, I think that was Dr. Jason Miller, right?
Yeah. Okay, so I wanted to show some social proof of one of Evan's clients. I'm gonna go ahead and share my screen. And this is in the PI Doctors Elite community, of which I'm a sponsor. Dr. Katz is a sponsor in this community as well, just helping chiropractors all across the country in certain aspects of personal injury. I'll put you in front of the doctors. Evan's company will show you how to really amplify your skills, your knowledge, your notes, and all that stuff that we just covered. So, Evan, why don't you just explain this, what your client and how your professionally integrated website helped Dr. Miller obtain this settlement?
Yeah, Dr. Jason Miller is an awesome doc. And, he put here that he had a case that he got paid 14 grand and that didn't include $4,000 for writing a narrative. And basically, I mean, this is not unusual, right? He was able to use the site to document what his diagnosis was and what they meant, right? So he knew, like, okay, the insurance company first argued it, and then they just coughed up policy limits because it was like, okay, we're going to court. He's going to be able to show his notes. He's going to be able to show from day one that we gave all this information to the insurance company beforehand, and they still ignored it. And then you could just ask them, and it's like, okay, they can get off easy by just paying the policy limits, and the patient needed care. So he just used the site similar to how I showed you here. Use it, document it. He documented loss of curve, instability. And yeah, he didn't even see, this patient didn't even get evaluated for 2 years after the crash. And he just, used the information about crashes, what he found on imaging, how that's related to the findings. And he got a great, and that validated his treatment.
2 years after the crash.
2 years after the crash. Yeah, that one's good, man. Like that's hard.
Yeah.
I won't lie on that. But I'd be like, man, we can show that this is from pathologies, but that's going to be hard. Like, why did the patient not get care? But he was able to, obviously the patient had a reason that he probably put in his notes. Hey, I was feeling good. Maybe they, I took some Tylenol. It just kept getting worse and worse. And maybe there's some documentation of them saying that their job, their neck hurt, who knows? But they didn't get evaluated for 2 years, and he was able to show it and use the site.
It's incredible, man. And professionally integrated on your website. And you've got instructions on how to take better soap notes, how to write expert narratives, not just, cherry picking from some Colossus seminar you went to, but just step-by-step instructions. And you really talk about the why you do everything, the why.
Right. The why, and the why of why does this patient hurt, right? Why did this trauma? And again, I don't care if the person fell out of a bunk bed or a ski crash or a crash. Here's what I found. Here's what it means, right? Now, when it gets to med legal, you're going to want to add in a little more causation and some other things, but I try to get it to just treat the patients the same way, educate them the same way. This is what you have. Why is this a problem? Why can this lead to problems? And then how can our care minimize that problem from getting worse? And that's what it's about, right? This whole thing with the days of like, oh, we want surgery injections to up the bill is not as important of explain why this affects this patient's quality of life. Why are they going to need care? Why might they need, okay, maybe they don't need surgery now, but could they maybe need it in the future? Can your treatment minimize that effect? Yeah, let me show you how. Here's the research that shows if this happens, this could get worse, but if we apply this, it could get better. And what's the likelihood that a patient in a crash is going to have chronic pain for the rest of their lives? Over 50%. But can we minimize that chronicity? So this whole thing, I think I've been asked this a million times and I don't have a great answer for it. People are like, well, Dr. Katz, like, can you show me what your, what is it called? Like end of treatment plan or your release record is? And I'm like, I don't have one. I know it sounds messed up, but and here's my question for that. If now in some patients, of course, they're better, they're done. But the ones that we talked about that you see, AMSI or loss of curve, some of the other things, and I asked docs this, I'm like, so let me just get this straight. You are saying that they have a 25 to 28% rateable impairment. You're saying it's a permanent injury. You're saying that it's bad, right? Whatever, they don't really go too far in bad. I'm like, so isn't it unethical to release that patient from care? Don't they need care? And they're like, well, at MMI, I'm like, well, what's the definition of MMI? And do you know what the definition of MMI is?
Well, I know what it stands for, not necessarily the definition.
But the definition of MMI is, will that patient not get worse if you do nothing for 12 months? So you put in your notes that this loss of curve, especially if you use professionally integrated, will lead to, there's a study on here I have from Journal of Medicine, an abnormal curve leads to disc herniations down the road or arthritis. So you're telling me you documented all this. They have a 25% whole body impairment, but you're going to release them from care? That doesn't make sense to me.
Right.
It's like saying to a patient that came in with high blood pressure, hey, you know what? Your high blood pressure might cause a heart attack. Don't ever come back to my office. You're done.
Right.
Like, you just established that there's some real problems, but now you're releasing them? Oh, well, my treatment is just palliative. Or does it prevent them from getting worse? Like, or, oh, well, my care, like, well, then if your care wasn't necessary, then why were you treating them in the first place? And then who are you going to send them to for these pathologies that you said are permanent and progressive?
Yeah.
So your treatment doesn't minimize that progressive nature. So now it doesn't mean I could just say like, hey, patient feels really good. I think that they may flare up. And if they do flare up, then they should come in because it's a direct result of this crash. But I'm not releasing them. I'm like, hey, you're doing pretty good. But based on all the things I've said for the last 6 months or a year, you might have problems. And when that arises, come in. And what's that? Why do you have that problem? Because of that crash.
Makes sense, man.
Makes total sense. But we don't see them like, oh, I treated them 20 times, then I released them. Like, okay, I mean, if it's for a sprain strain, you should release them. But if you diagnose like some of these other things, like, oh, 25%, if 25% whole body, the attorney's going to like this, and then you release them. I mean, man, if I was a defense attorney, I'd be like, oh, cool. So they were done. They don't need anything else. So then all your other stuff that you're trying to say is a problem. Oh, so you released your patient with a problem? Yeah. So they're worse now. Yeah. Well, if you treat them, could they have been better? Well, yeah. So then maybe you're the reason they're worse.
Right. Yeah. Makes sense. Yeah.
Yeah.
Well, Evan, I really appreciate you doing this interview for me because my clients, I get this question a lot. My lights are on a timer.
Oh, look at that. We took up all the time, man.
That's right. That's right. Yeah. So my clients, they ask, what should I talk about at Zoom calls and what should I present? I mean, presenting your stuff to them, I think it's just going to turn them on because very few chiropractors are showing that just empirical evidence of the care, why the care is necessary and why they may need more care even after you release them or consider releasing them.
And the other thing too with that is it's unfortunate that most of the attorneys that they don't know about this until I talk to them or another professionally integrated doc is they're educated by what we've been telling them. And I think we've been telling them wrong for decades. Sprain strain, cervicalgia, so they fight. So they're used to like getting 10 grand, right? And then you get the ones that are educated and then it just makes it easier of like, no, this patient deserves the treatment. And the insurance companies know this. They know these patients are hurt, right? All you're doing is presenting the information that the research and our clinical experience has been saying for decades, but not how we've been taught. We've been taught to cater to these mills to just get a quick buck, play the game, but not to be docs. And, the other thing that's kind of fascinating too, off topic is, you hear about these, oh, I'm a PI doc. Right? I'm a PI doc. And I'm like, well, what does that mean? And they're like, oh, well, send it to a surgeon. There's some that know, but next time you send your patient with instability to a neurosurgeon, be like, I'm sending him for AOMSI. Do you know what that neurosurgeon's going to say? He's going to be like, what is that? Like, no joke. Why? Because AOMSI is not a diagnosis. But if you say to the surgeon, hey, I have a patient here with a posterior column injury, most likely tearing of the PLL, they're going to know what that means.
Yeah.
So use your notes that way. And don't use, the insurance stuff because you're just painting yourself into a corner and the whole colossus, little things with attorneys is you're painting yourself into, or you're getting yourself into a system that was designed to keep us down and stupid.
Makes sense. That's right.
So
Evan, I mean, I know that Professionally Integrated, your website has a free version. Now, what if one of my clients wants to sign up and get the paid version, the gold or platinum? I mean, you provide so much information. You're always updating it. I mean, that website's probably got $1 million of information. So I'm really hesitant to ask, how expensive is it to join Professionally Integrated at your gold or platinum level?
It's just stupid cheap. It's less than one patient visit, right? So I charge only $100, right? No contract.
$100 a month, right?
$100 a month, no contract. If you can't make your money back by educating patients on what you do, then call me and I'll really help you understand how to use it. And then I do have where it's only open to so many people, a premium, which is $250 a month. And with that, you don't really pay for a whole lot on gold. Every once in a while, there might be a webinar that, might cost you a couple bucks compared to free at premium. But with the premium, I will also give you my time where I'm like, send me your notes. Like, let's start and let's just see. And then I'll do a Zoom like this, where I'll look at your notes, I'll break it down and show you like, hey, let me show you what you should add here. Let me explain why this is better. And let me show you how to use the site specifically to add it into your notes and documentation. But because I have a full-time practice, I can only offer that to so many, but man, it's less than a cup of coffee a day. Like if
having this information, like, dude, we make handouts like it's $100. Like
I
$100
mean,
bucks.
it's
like,
incredible for
and
the
again, I'm not
amount-
trying to make it rich. I use it for my own practice. I just want docs to have this, like raise the bar together, make it
raise your standards.
because-
I talk about that all
raise
the
the standard,
time.
because if there's right now it's 99% are barely able to validate $3,000 and they're happy to take $1,800. Imagine if it was the other way around. 99% of all docs doing PI were like, our bills are 14,000 for this. Everyone's going to expect that's what should be done. It just helps us all. Here, use it, please. Make it easier for me.
Right.
You know, because I run up with these attorneys like, well, you know, the ones that don't, well, how come the doc down the street will take $3,000? I'm like, well, let me take a look at what they're doing, because they're giving you a fraction of what needs to be done. You can't fight this. There's no way you can go into court with these notes, this documentation, and the explanation of what they said the injury is. You're done. You're going to lose. Like, you're going to lose because it doesn't reflect what's wrong with that patient.
Yeah. Well, Evan, how can we get in touch with you?
Yeah, just go to professionallyintegrated.com. You know, that's one way. My cell phone is 303-594-8969. You can shoot me a text. You know, and on Professionally Integrated, there's also like a, you know,
Contact
thing on there. Yeah, that you can, you know, email, and then I have an IT person that will get it and send it to me. And yeah, I mean, that's it.
Love it, Evan. Evan, thank you so much for doing this interview. I think you shed a lot of light on what these doctors can be doing to get better settlement offers, help their patients even more, document the injuries, prove causation. And when you get in front of attorneys, whether it's a lunch or a Zoom call, show them this stuff and how you reference medical journals, journals of neuroscience, journals of orthopedic surgery. I mean, because there's this joke going around in PI, if you don't have a medical doctor, you know, most attorneys want the blessing of the medical doctor on their PI cases, but you only need 2 letters after your name to be very successful in personal injury. And it's DC. And using your stuff can get you get you compensated for the hard work that you paid a lot of money for in college, went into heavy debt on, get paid for this hard work, but you just have to have the knowledge. You have to have the
knowledge. Yeah, if you know, if an attorney asks you questions and you can't answer it, you know, you're like, you need to, and that's the thing with this site is it's not just an easy button copy and paste. It's for you to listen and to read and really understand what these pathologies mean. So there's nothing that they can ask you that's going to rattle you, right? Because you're not there to win the case. You're like, hey, patient came in with instability at 5'6". Here's a paper that shows this. Here's what this means. That's what this means. That's a problem. Like, that's it. What can they say? Oh, they should have been better. I've never seen anything. In fact, the notes that I put, the references I have in my notes actually say differently. So I'm not, if you have any evidence to show that a loss occurred or instability would just spontaneously resolve, I'd love to see it.
Yeah.
But I haven't seen that so far. And there it is. So they can't like, oh, well, what about this? Or why'd you do that? Like, I treated this patient and you know, on the site too, under webinars, I have a couple of webinars with like attorneys and legal experts. And one of them was with these attorneys where we got a $300,000 settlement, chiropractic only, no MD, no nothing. And it was like, why? It was like, well, because we did a deposition with the defense attorney who thought, and I was like, oh no, here's this, here's that. And it was like, it's objective. There it is. So what do you want to do? Like, yeah, and I think that's the other thing too. Like, I mean, it's a whole other issue, and I understand the MD, but there's some great MDs that I have on the site. I do a webinar with a neurosurgeon about what he looks for. I have inventors of orthobiologics. That's who I usually send for. But when it comes to like cortisone and, you know, stuff like that, the question I always ask is like, well, why are you sending it to this ortho? Why are you sending, like, is there a surgery that can fix this? Because why can't we help that? And if you could just explain why this patient needs our care, then you validate your treatment. And then the jury or the adjuster realizes this isn't about building the bills with injections or surgery. It's about understanding how this pathology or these pathologies that we document affect this patient's life, both in the short and the long term. And that's where it really comes out. Like, yeah, man, this patient's functioning, but not as good as before. And here's why. What's that worth? You know, like, what's it worth to a woman that can't cuddle with their partner because of their head being forward, and you diagnose and you document that. But if your treatment is allowing them to cuddle, is that unnecessary care? Of course not. but then you can correlate to their pathology, to your treatment, to why it's helping them and why they can't do those things.
Right, because we talk about in personal injury, if you're trained in a certain way to write reports, loss of enjoyment of life.
Absolutely.
Not being able to cuddle with your spouse or partner, that's loss of enjoyment of life. And if you're able to help that, that has immense value.
And to take it a step further, the patient can't ski anymore. But then the next question is, well, why? Well, did you put in the notes that they had, abnormal curve or instability or facet, and it makes it less stable? It causes more shearing force. Is that in the notes? And if it's not, then you can't connect it. So you could say, hey, this patient can't do these things because of the things I documented starting on day 1. I mentioned it again on day 7, 15, wherever. It's in there. I explained that from the beginning as opposed to waiting to the end. So I just put it in the notes, and then it just makes it great when the insurance company's like, well, we don't think so. I'm like, well, all the information is there. We gave it to you and you're ignoring it. Great. That just helps us.
Right. See you in court.
See you in court. Because we gave you the information to make an appropriate decision. In the same way, when they lowball and the attorney can't get more, it's like, well, you gave them the information, and your information is they had neck pain.
Right.
Okay.
They're maximizing what you gave them.
That's it. And if they're underutilizing what you gave them, then you're like, then we'll see you in court.
Right.
But it's like, just give them the information, right? Yeah. Give it to them. Don't be afraid. Like, you should be proud to be like, I'm treating them for this, this, and this. Yeah. Give it to them up front. And my site, just copy, paste, put it on. And then it's like, and we've seen it before where, the IME comes in, I don't think so. And then IME is like, okay, well, what about this reference here? Dr. Katz talks about, from Journal of Neurosurgery, how this, you didn't mention that. How about this? You didn't mention that. How about that? You didn't mention that. So explain, what did you come up with in his notes that you think the patient should have been better? How much are you being paid again? We'll see you in court. And then the defense attorney is like, we should probably not let this one go to court. Like, what's the policy? And that's how it is. It's not, they're trying to pull the wool over our eyes. I'm just trying to educate. Right? I don't care. I'm not here to get you a big settlement. I'm not trying to help the attorney. I just want you to get healthy, and I want you to understand why this pathology, whether from a crash or something else, is affecting you and how I'm trying to help you.
Yeah.
Period.
Yeah. It's just if your notes are better and you can reference medical journals of why the treatment was needed, then you're just going to do better as a doctor, whether it's a cash patient or insurance patient or PI patient.
And think about how much having this information is showing it to patients every day. An educated patient gets better, and an educated patient refers, right? Because they know, like, oh my God, he explained this to me. This makes a lot of sense. Oh, I understand why I shouldn't look with my head down. Like, that's all we use the site for, education, right? And whether I'm educating a patient, an attorney, or a defense attorney, I don't care. I'll educate you all the exact same way. This is what you have. This is what I know. Here it is. Here's how it's affecting you.
And if you create this new habit of learning something new to help your patient and explain it to the patient, repetition is the mother of skill. You're going to get better explaining it to an attorney, explaining it to an adjuster, or, just explaining it to your patients. To your patients, that's right. I love it.
Yep, absolutely. And then they can't, and then what are they going to argue? Like, what's an IME going to say to me? Like, oh, the upper cervical instability or kyphosis is no big deal. Like, okay, we can talk about that all day. Right. Ask me whatever you want.
Yeah, I love that. Evan, again, thank you so much for doing this interview with me. I think you shed a lot of light. You offer a lot of value. So reach out to Evan. Go to professionallyintegrated.com. I mean, his paid service is $100 a month for $1,200. All the stuff that's on there that can help you help your patients more, take better notes, better documentation, and let's just say it, get paid more.
Yeah, you have to increase your value, right? Yeah. And if you understand what these injuries are, then you have more value, and your patients see that there's more value. I mean, I never get tired of a patient coming in and be like, how come no one else told me this? I don't know, because you're paying them $20 and they milled you through. I'm trying to educate you. So yeah, and take the time, just continue to educate yourself. And then you can relay that to your patients to get better outcomes.
Yeah, it's all a matter of just raising the doctor's standards, his standard of care in the clinic, and be able to explain it. That's how they're going to get bigger settlements.
That's right.
At settlement time. Yeah.
Yep.
Evan, I love it. Thank you so much for spending this time with me. I know you're a very busy man. You got a busy practice. You're helping other doctors with Professionally Integrated. So again, Thank you so much for doing this interview.
Thank you so much. And thanks for everything you do too, to get us in front of all the people so we can explain what we do and why. What we do is so important, and we just have to be able to explain it and show it.
Absolutely. Well, Dr. Katz, again, thanks so much. And
Thank you.
have a great week. We'll talk soon.
You too.
Bye.